Hello, everyone. Welcome back to the channel. My name is Nathan. I'm currently a med student at Northwestern and just recently started my third year clerkships. I'm here today with Dr. Reza Manesh, who's a clinician educator at the West Los Angeles VA. He works with medical students and residents, and he has a ton of clinical insight and pearls to share with us. So we're here to ask him a few questions about internal medicine.
Hi, Nathan. How are you?
Yeah, wonderful. Yeah, this past week I was in Maine doing this program for the American Society of Nephrology, the kidney treks program. I don't know if you're familiar with it, but it was kind of like a research program. So we did experiments to learn about renal physiology, but then we had a lot of downtime as well, to explore Acadia National Parks. We did a lot of hiking, biking, kayaking. So yeah, it was a lot of fun.
That's awesome. I'm a huge fan of a Netflix series by the creator of Everyone Loves Raymond, and it's
Mhm.
titled "Someone Feed Phil." And he was in Maine, and it seemed like a beautiful place that I have to visit.
Oh yeah, yeah, it was beautiful.
All right, so Nathan, I know you had contacted me because you wanted some tips before you start your, is it your sub-I that you're starting or your internal medicine core clerkship?
Yeah, just my internal medicine rotation. Basically, yeah, I was just wondering what advice or insight you had about internal medicine, for that rotation. At least right now, I feel like I'm leaning pretty heavily towards internal medicine. I think so. Within IM, I'm pretty open to pretty much all the fields within IM, but IM, I feel like is right now what I'm leaning towards doing. So I was just wondering what advice you had for the clerkship in terms of how to do well in the clerkship, but just also more generally how to get the most out of this experience.
Awesome. And I think that the principles that I'll discuss, and I'll pause after I discuss a few to see what questions you have for me to clarify, probably apply to most of the rotations that you're going to partake in, and also probably apply to your career, going forward once you're actually working, as a clinician educator or as a clinician in a community-based hospital. I'll start with how can you get the most out of the rotation? Because I think that's more
Mm,
important. I know it doesn't seem that way than the grade, but we'll talk about the grade as well. As far as getting the most out of the IM rotation, every clinician has to have the fundamental skills of internal medicine,
mm,
because the procedure that we do in IM is diagnosis. And that's probably one of the most important questions you can answer for any patient presenting to your care. Because what does the patient care about, Nathan? They care about their prognosis and what can be done about their condition. But it's hard to do either of those without an actual diagnosis. So this is a time for you to really practice your diagnostic skills. You'll do this on many rotations, but you'll have the unique space based on the number of patients you're caring for to really dive deeply into the world of diagnosis.
mm,
So in this regard, how can you improve your diagnostic skills? It primarily is going to occur when you're typing up your note. So
mm,
specifically in the assessment and plan, that's where your diagnostic skills are really highlighted. And this is why when you're doing a presentation, we'll talk about oral case presentations, you want to try to spend less time in the sections preceding the assessment and plan, because there is where you get to demonstrate your thinking. And your thinking is what's one of the most important skills you actually need to develop for your patients. So when you go to the assessment and plan, and if you're taking care of 3 patients, 4 patients, you'll be able to access up to date or whatever resources are available at your institution. And you'll be able to utilize them to come up with solid thinking. So let me give you an example. I think that's the way it works out best. Let's say someone's coming in with shortness of breath. And of course, you got your HPI, your past medical, surgical, family, allergy, exam, and then laboratory data, imaging, et cetera. And now you're getting to your one-liner. So the one-liner you have to work on, and that's something you have to develop during your IM rotation, during any rotation. And I will tell you that it's not easy. Like a solid and concise one-liner is not easy. And I'm gonna actually go a little tangential here. To get the most out of any experience, you need specific goals. You shouldn't be like, I want to learn the cardiac exam. That's too broad. Maybe you say, I want to learn how to assess the JVP. You shouldn't say, I want to learn ultrasound. I want to learn ultrasound. Maybe you say, I want to learn how to assess the IVC. So you need like specific targeted goals. That may be a few days, that may be the whole rotation, that may be a few weeks, but it has to be targeted. And they've shown this in studies, and that's the way we improve most. So I would say for anyone starting their internal medicine rotation, one of the goals should be coming up with a concise one-liner known as the problem representation. It really has three components, like who is the patient? When is their time course? So who, the time course, and what is their clinical presentation, the clinical syndrome, the who, the when, the what. So note that this is different than saying like, this is an 87-year-old whose youngest daughter got diagnosed with this and brother had this. That's too long already. The who is like the age, the gender, and any relevant, past medical history or epidemiologic clues. The time course is it hyperacute, acute, subacute, chronic? And then the clinical syndrome, like what are you trying to solve? So this is on day one admission, right? You have this concise problem representation. And guess what? On day two, when you're waiting for the CT scan and it comes back, now you incorporate that CT scan into your one-liner because it's an updated problem representation as more data is being accrued. So you have your problem representation. Then something that all of you should work towards achieving too is a prioritized problem list. On day one, it's pretty straightforward because the patient's coming to the emergency department with a specific chief concern or is being referred by a primary care doctor with a specific chief concern. So that becomes your number one problem. So a prioritized problem is really important. So now we say the prioritized problem is dyspnea. You don't want to anchor early on day one of hospitalization, even if that chest x-ray shows a consolidation, because remember, pneumonia is not a radiographic diagnosis, it's a clinical diagnosis. The radiograph helps support the ultimate diagnosis. So you still should start with shortness of breath as opposed to community-acquired pneumonia on day one. Then when you're talking about shortness of breath, here's your opportunity to challenge yourself as to the various etiologies. And you might say that shortness of breath, it can be from pathology of the heart, the lung, or other systems. I don't think it's the heart because then you talk about heart failure, you talk about coronary artery disease, you talk about arrhythmias, then you say, I think it's the lungs because there's a leukocytosis, there is a fever, and there is a consolidation with the patient's productive cough. I'm worried about community-acquired pneumonia. I don't think it's a pulmonary embolus because we have an alternative diagnosis, and I use, the Wells scoring system. This is on day one, right? So on day one, if you're presenting an H&P, maybe spending 7 minutes. I know it sounds, and it probably won't happen because it's so hard, but 5 to 7 minutes on all the preceding information. And then a good, 7 minutes on your assessment and plan with like probably the most time spent on the number one problem. And once you have your assessment, then you can break on day one your number one problem into diagnostics and treatment, because that's what we're doing for patients in the hospital. So you might say diagnostically, we're waiting for a urine strep, a urine Legionella, and sputum cultures. Treatment-wise, based on our antibiotic guidelines, we're going to initiate these antibiotics for community-acquired pneumonia for X number of days. So note, like you want to give the duration, the kind of antibiotic, and your rationale for which antibiotics you use. Problem number two, now you might say that these are like the acute like issues. And then problem number two, are still like active issues that you're managing in the hospital, but they may represent the patient's like chronic illness. And you have to still consider prioritizing stuff. So like if this patient has diabetes and the A1C was 12 and the glucose is all over the place, maybe problem number 2 is diabetes. And then you should say at the home regimen is X. In the hospital, we're going to do Y, the letter Y. And you'll talk about the long acting, the short acting, the nutritional. Problem number 3 might be the patient's heart failure or hypertension. And here you might say you're holding the giving your logic because the patient is presenting with sepsis, for example. Then if you want to take it to the next level, you can say, these are the chronic issues that are stable, the CKD, the hyperlipidemia, the neuropathy, the glaucoma, and say that the patient's on their home regimen. Say it, and you might ask, like, do you want me to elaborate on what those medications are? I would say if you're just starting, like, err on the side of elaborating, but you can always ask, like, these are the chronic issues. COPD, we continued their home medication. Heart failure, continued the homework. But if there's anything that you're adjusting or modifying, then it's worth like at least 30 seconds to a minute. Then you want to end up with the bundle. And that bundle is going to be true for every patient. Like, what is their pharmacologic prophylaxis? What is their diet? What is their code status? And what is their disposition? You should think about what that bundle is for you as the days go by. But I would say, like, one of your first goals starting your 3rd year clerkship in internal medicine is being able to present efficiently, find yourself in the assessment and plan for the majority of your H&P presentation, have a prioritized list with the majority of time spent in the number 1 problem, keep it open on day 1, don't close it, and then have a bundle so you can be very systematic.
All right. Wow, yeah, that's some wonderful advice there. So it sounds like really focusing on the assessment and plan aspect of like your H&P to like really develop your clinical reasoning. Right?
100%. And so then if you're going now to day 2 of the same patient, now you're convinced it's community-acquired pneumonia. Now your number 1 problem is community-acquired pneumonia. And you don't need to go on a long, assessment anymore. So on day 2, like, your progress note presentation shouldn't be more than 5 minutes. It really shouldn't. And it's good to be very systematic. You can either include your one-liner at the start of your oral presentation, or you can put it right before you problem list. You might ask your attending or your resident, like, where would you like me to incorporate the one-liner? But what you don't want to do is repeat it twice because it's redundant. Like saying it, this is a 54-year-old with COPD, here with shortness of breath, leukocytosis, and a chest x-ray with consolidation, consistent with community-acquired pneumonia. That might end up being like a 54-year-old here with community-acquired pneumonia.
On subsequent days.
On subsequent days. But you don't want that. You don't want to repeat that twice where you say it and then say overnight events, this happened, blah, 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 blah. Then again, you give the one-liner and then you problem list. So just do it once, either at the beginning or right before you problem list. You see, you want your presentations to always be problem-based when you're on the general medicine service. In the ICU, they do organ system, but even within organ systems, then they problem list. That's a way for them not to miss any specific organ system. So on day 2, when you're doing your SOAP, I would start with you should always have a paper in your hand with the data, but maybe one of your goals by the end of your month, so this is not so much a 1-week goal, but an end of the month goal, is being able to do SOAP presentations and HMPs without looking at your paper, because you're trying to narrate a story for the audience. You're narrating a story. So when you're narrating a story, it's much easier not to look down, because then it becomes much more of like a dictation. And you want to structure. So like you just memorize like the SOAP note. It's called SOAP note for a reason. Subjectively, objectively, assessment and plan. So when I was a student, I would tell myself, you have to add an O, it's OSOAP, because you have to add overnight events. What goes into the overnight events? Like, that's so subjective. Like but an overnight event isn't like the patient wanted to speak to the the on-call resident. That shouldn't make the overnight. An overnight event might be like The patient aspirated, became hypoxemic. But you have to be cautious, like you're not too redundant. Like you don't want to start with your assessment and plan in the overnight event. Just say it, and that's another important pitfall I see in a lot of presentations is people start giving like their assessment and plan during their presentations. But remember, when you're giving your presentation, you're not really sharing your thinking at that point. It's just giving data. It's just giving data. It's all data. So then you have to, so I would be like overnight events or no overnight events. Subjectively, this morning, the patient doesn't have chest pain, doesn't have a cough, feels that their shortness of breath is improving. Physical exam, vital signs are within normal limits. You might ask, like, do you want me to read out the vital signs? It's always good to read out the vital signs, but it all depends on what your team wants. You'll see that a lot of this is subjective. So always are on the side of asking, but you don't want to ask. Now this goes into like getting a good grade. You don't want to just ask a million questions, right? Like you don't want to say, should I say, but it's fair to ask like during the presentation, do you want me to read out every single vital? Vital signs are normal. Do you want me to read them out? No, that's okay. The exam is unchanged from yesterday. Now, this is as you're getting to your week 2, week 3, but it's much more efficient because you're going to get to the assessment and plan quicker rather than saying, pupils equal, round, and reactive. Like no one wants to hear that on day 2 unless you're dealing with a neuro-based presentation. You see, like you want everything to be relevant. Like if it's someone with pneumonia, what shows me that you're thinking is that you're focusing on the vitals, the temperature. You're focusing on the respiratory exam because that's pneumonias of the lung. And so like, I want to know, is there inflammation and what are the lungs doing? But if the patient also had COPD, you're telling me that, look, there's no wheezing. Or if they had heart failure, you're telling me that, look, since they came in with pneumonia, we held their diuretics, for example, or we were worried about their hypotension. You're telling me that their JVP isn't at the earlobe, for example. So you want to be thoughtful. So I'm like, subjectively this, objectively, I give the vitals, I give the exam, and I give the data. Those are all objective, and there you want to show trends. So it's not like the white blood cell count is 8. What was it yesterday? If you're telling me what the I want to know what it was yesterday. So it was 8 from 12. That's good, Or in the HMP, if you're giving me a creatinine of 3, I want to know what is the baseline creatinine, because laboratory measurements aren't just one moment in time. Their sort of trajectory tells us a lot. Then you go straight to the assessment and plan. And here, if you didn't use the one-liner yet, you might say 54-year-old here with community-acquired pneumonia. Problem number one, community-acquired is on day 2 of these antibiotics. The diagnostics, the urine strep, the urine Legionella, you might repeat it, but you probably don't if you already included in the data above. And the plan is to complete this many more days of antibiotics. I think the patient is stable now to convert to oral antibiotics. I plan to do an ambulatory O2 sat test. And if they pass, I think the patient can be discharged. Problem number 2, if there is a problem number 2, or you might say like all other issues are stable. Would you like me to elaborate? It's good in the start of your rotation to actually list them out. Problem number 2 is heart failure. We're resuming the diuretic therapy. The patient's blood pressure is stable. Problem number 3, COPD is on their inhalers, is asymptomatic. Problem number 4, the patient's CKD creatinine is at baseline. The bundle, the diet is this, the pharmacologic prophylaxis is this, the discharge plan is this. And I'll just say one thing too. Let's say overnight, all of a sudden the patient became confused. Now maybe confusion becomes your number 1 problem. You see, this is a reprioritization of the problem list. It shows that you're thinking, that you're going beyond the basics.
All right. So it sounds like the bundles that you're talking about are for like each problem and kind of like your plan for that, like the treatment and like if the patient can be discharge plan. Is that what you mean by this bundle?
Thanks for asking that. So no, the bundle is like just basically at the end of the assessment and plan, because it's only at the end that like where you just want to make sure you don't forget stuff, like you don't forget the DVT prophylaxis. If they're not on enoxaparin or they're not on heparin, then asking why, like because they're at bleeding risk or their platelets are really low. The diet, the disposition, all that comes at the end as like, that's what they refer to as the bundle. But in your problem list, especially your main problems, like the number 1 problem, you can break that down into diet, DX, and RX, because that keeps you very structured. and it keeps the audience structured in your presentation. So but then the subsequent problems, you don't need to be as, thorough unless they're active.
Okay. So the bundle is kind of like its own section after you discuss all the different problems. Is that correct? Okay.
Correct. And I would advise the students to say like problem number one, problem number two, because that's, again, showing everyone that you're prioritizing the problem-based presentation.
Okay. And then what would be the best way to introduce the bundle at the end?
Oh, so the bundle at the end, I wouldn't even say their bundle. I would just go into saying, for DVT prophylaxis, the patient is on Lovenox. For diet, it's a regular diet, or there's 2-gram salt restriction. Their code status should be part of that. Code status is full code. Disposition. So on day one, like I always want to hear what the code status is. I think most do. So it would make it into the bottom of the presentation, unless it's the number one problem. Like someone's coming in, they're dying. Then I want to hear it as the number one problem, like they're being admitted to die in the hospital, which happens sometimes. Then that should be your number, like goals of care. The patient doesn't want any like aggressive intervention. That's your number one problem. But I would say every day, you probably want to talk about disposition. I mean, that's like superb. Even if it's like the patient's really sick, disposition, patient needs continued inpatient care. Disposition, we think the patient's ready for discharge medically, but there's some issues because we're trying to figure out how to get them to a skilled nursing facility. Or disposition is pending a physical therapist evaluation. This bundle is just subjective. You might put PTOT in your bundle as a way to remember. You might put nutrition in your bundle as a way to remember that. Like for me, I always put DVT prophylaxis, diet, code status, and disposition. But you'll come up with your own thing that it's like when pilots have their checklist, and that's how we have prevented so many errors. This becomes your checklist. And like what you decide to present, I would say always present disposition, but you may not want to keep repeating the pharmacologic prophylaxis or the diet. That's up to you, but I think disposition is always important to mention at the end. Yeah, the other one's less so unless it's relevant. But on day one, I would mention the other one. But let's say on day one, the patient had like scant hemoptysis, and you're like, we're not starting pharmacologic prophylaxis because of this. On day two, let's say the hemoptysis is not there, or like there's no concern, the hemoglobin is stable. You're like, now we're starting the part. So like, since there's that change, then you should say it at the end of your presentation.
Okay.
You see, these aren't large enough to have their own problem list, because it shouldn't be like problem number one, what is our pharmacologic prophylaxis? So they come at the end as the bundle.
Okay, great. Would you mind clarifying again, like what you mean by disposition? Because I think for a lot of students starting clerkships, and like myself included, that's a term we aren't really familiar with before.
Please keep asking these questions, okay? Like it's crucial, because I want to make sure everyone understands what I'm saying. By disposition, it means like discharge. Like, so now, you took this patient from their environment, wherever that is, and now they're in the hospital. So every day we should be asking ourselves, can they be discharged? Why? Because the longer a patient stays in the hospital, the more deconditioned they'll become, the more at risk they are for iatrogenic, hospital-based complications. So the quicker they get, actually one of my favorite professors, primary care doctor, he would always do his best to get his patients out of the hospital as quick as possible, or not even get them to the hospital because of the complications that might occur. But of course, the hospital is needed for some people. So it's when that threshold's overcome, they should be in the hospital. So everyday disposition means like, where can they be discharged to? Maybe they can't be because you're still giving IV antibiotics or IV diuretic therapy, but you should still mention it to show everyone that you thought about it, because you should be thinking about it.
Okay. And then in terms of like framing it in the, like when you're actually saying it, do you like use the term disposition, or how would you introduce?
Yes,
that
disposition.
line?
Exactly right.
Okay.
And in the note, it would be like disposition, colon. It would be code status, colon. DVT prophylaxis, colon, diet, colon. And those are all right together. While the problems are separated by at least a space to show that they're different. You might put like hashtag shortness of breath. I know your generation loves the hashtag. So.
Yeah. Yeah. Okay, yeah. Another question I had about like the assessment and plan is like what insight you'd have or advice for creating the differential diagnosis. Like, do you think like organ-based approach is best? Or I know there's like a lot of different mnemonics out there to help approach it, but yeah, what are your thoughts about the differential
This is a
diag?
great question because, and this goes back to the second thing that you want to talk about, like grades. You don't want to spend 30 minutes with any presentation. No one will like you if you're talking for
Mhm.
30 minutes. And people are kind, they'll let you go. And look, it's not where you start, but like it's the improvement you make. You're not going to be perfect on day one. I mean, if you were perfect, you wouldn't be doing your rotation, right?
Mhm.
So I want everyone to realize that you should assume that you're at starting at zero, which is
Mhm.
not true, but that's like the expectation I have of like the new third-year medical students who are starting. But then by the end of it, they're all stars. They really are, because with feedback, um, they improve tremendously. So this goes into like your number one problem, shortness of breath. You shouldn't list 13 possible diagnoses. That's too many.
Mm.
You shouldn't be saying, oh, methemoglobinemia might lead to dyspnea, but I don't want to hear about it unless it's relevant. Thyrotoxicosis can lead to the sensation of dyspnea, but I don't want to hear about it unless it's relevant. But for all patients, I want to hear, like, for dyspnea, is it the heart or is it the lung? Because 95% of dyspnea is due to one of those two organs. So I would say when it comes to time to your DDX, try to list 4 possible diagnoses for your number one problem on
Mhm.
day one.
Mhm.
On day 2, like when it's community-acquired pneumonia, and by the way, just because you have one diagnosis doesn't mean you don't have another. We see this often, patients who have a history of heart failure, they get pneumonia, that results in decompensated heart failure. So now they have pneumonia contributing to their shortness of breath on day one, and heart failure, also edema, contributing to their shortness of breath. So your treatment might actually include diuresis and antimicrobial therapy. So I would say on day one, challenge yourself to list at least 4 diagnoses and rate them, but be open to the fact that you might have multiple contributing to the number one problem. On day 2, then you're separating it, like the community-acquired pneumonia. So when you discuss the one-liner, you might say 54-year-old here with community-acquired pneumonia and decompensated heart failure. The shortness of breath is improving. Problem number 1, community-acquired pneumonia. Because you just told us, wow, like the patient's getting better with our intervention.
Mhm.
You see, and by the way, because this interaction isn't about like an approach to heart failure or pneumonia, but you'll develop those approaches where, like when you talk about heart failure, like every day you should report the weight, the electrolytes, the ins and outs, because those are all relevant,
Mhm.
to what we end up diet. But that you'll learn. You shouldn't know that right now, but these frameworks are so helpful. So when you develop them, store them somewhere, and then you can keep applying them going forward. On day 2, there's no reason to list the DDX if you now are at community-acquired pneumonia.
Mhm.
But if the patient became altered overnight, now altered mental status becomes your number one problem.
Mm.
What are 4 possible causes of altered mental status, for example? It's okay to go beyond that, but you just got to be cautious that you don't spend too much time, because there are, believe it or not, there's 14 other patients we have to see. There's other students, there's other residents. So you want to be cognizant, and this goes into your emotional intelligence of like, and situational awareness of like what the team is trying to accomplish, because the ultimate goal of the team is to provide extraordinary patient care. The ultimate goal of the teaching physician is to provide extraordinary patient care and extraordinary teaching and watch the trainees grow. So you have to be aware of the situation. Like the world doesn't revolve around any of us, but you do deserve the right to improve, and we want you to improve. And by the way, you are going to allow us to provide better care. You really are. It isn't just about you learning. Like, you're in the unique position to actually spend an hour with your patient, an hour talking to your, it's, when you go into practice, as an attending, it's difficult. You have 15 patients. You can't spend an hour with each, but now you have that opportunity. You
Mhm.
have 2 hours to dive into charts and into the literature and like trying to advocate for your patient.
Mhm.
So the medical student can augment the care tremendously.
Mm.
In fact, recently a medical student was able to make a diagnosis that I missed that led to better patient outcome. And I applauded her and I
Wow.
congratulated, and it made me so happy. And that's like the power of crowdsourcing and group thinking. But to answer your question, try to come up with at least 3 to 4 of
Mm-hmm.
the most likely diagnoses for your patient. But day 2, it changes. Like just use common sense on like day 2, like you have a diagnosis. But if day 2, it's still unclear, the shortness of breath, then you should still be talking about why you think it's this, why you think it's that, or the patient didn't get better despite all our treatments. And we learned that, that they have this respiratory acidosis, and I saw some fasciculations. Now I'm worried about ALS,
Mm.
amyotrophic lateral sclerosis. So that's the way I think to approach it in that regard.
Okay. Oh, yeah. Some wonderful advice there. Yeah, and I think kind of going off of what we were just talking about, when you mentioned like med students having a lot more time to spend with patients and reviewing things, what like insight would you have for like the approach of that, like getting to spend a lot more time with the patients? Like, yeah, how should we as med students approach all this extra time?
Yes. So when I go into a patient's room, I find a chair and I sit in a chair. If there's not a chair, I ask the patient, can I sit on the bed next to them? I
Mm.
get permission from them because it's just so much more, it's so much more appropriate, enjoyable, relatable for the
Mm.
patient to see you at eye level. In fact,
Yeah.
they've done studies where they've shown that providers who sit down, the patients interpret them as spending like 10 times more time in the room, despite it being the same time.
Mm.
Like as opposed to being a minute, like even if you sit down for just a minute, they think you're there for like 5 minutes.
Mm.
So I think when you enter the room, like sitting down, when you turn on the light, like, I mean, this is all emotional intelligence. It's like situational awareness and emotional intelligence. If they're sleeping, like asking, can I turn on the light? Because you don't
Mhm.
want to shock them with the light being turned on and
Right.
hurting their eyes. Um, but you sit down. So with the extra time, I think really spending it at the bedside
Mm.
and not getting caught up in just being in front of a computer. There's like a great article, I think by Dr. Abraham Verghese, titled something like treat the patient, not the computer. But it just goes into this current era where like a lot of our time is just spent in front of a computer. So like taking advantage of spending 30 minutes and getting to know them from a social situation.
Mhm.
For instance, like you'll learn stuff like a patient was on the Titanic. Like you'll learn unusual stuff, and beyond that, it just shows them that you care about them more
Mhm.
than just a disease that you're trying to. It's a patient with the disease.
Mm.
It's not a 54-year-old alcoholic. It's a 54-year-old person with alcohol use disorder. It's not that sickler. It's a patient with sickle cell disease. So with that extra time, getting to know them, getting to know like what do they do for fun? Like what's their hobbies? Who are they? And if you incorporate that into your presentations for the team, they'll do it authentically and with excitement. That goes a far way. Like, wow, Nathan also cares about the person. Don't do it if you're not authentic about it. Let me just say that. Don't do anything for just the grade. I mean that wholeheartedly because people will be able to sniff that out. But how amazing is it to learn that, someone's family member like went through this arduous journey to come to this country, for instance, and then now is like the CEO of this company, for instance. Like that's like pretty sweet. So you'll learn some cool stuff. I think like practicing the physical exam, but that it might be helpful to do with someone who has experience. So one of your goals, if it is the JVP, you might ask the resident or the attending to help you assess the JVP on all your patients so you can know if it's descended or not. What else to do with the extra time? Like you don't want to just spend all the time in the patient's room, like reading, like learning, and getting lost in the patient's, problem. I would recommend that all the third-year medical students and anyone actually who's practicing medicine to download Glass Notebook. It's a free, program, online program where you can actually store medical information. You can store your patient cases, but make sure you do everything HIPAA compliant. You can put articles there, but as you're learning medicine, it's basically you're writing your own textbook in medicine, and it organizes it based on frameworks and illness scripts, and you'll learn all those terms. The co-founder and creator, Dr. Derek Paul, who's at Brigham Internal Medicine resident, sort of has like a little bit of a tutorial at the beginning that you guys can click on. But as you're learning topics, having a good electronic system to store those topics, so you don't have to learn the same facts over and over, and you can always access those facts when you need them. So with the extra time, it's time to read as much as you can with the knowledge and motivation, knowing that the more you read, the more enjoyable medicine is, and the better care you can provide to your fellow human being.
Yeah. Yeah, I think like getting to spend all that time at the bedside, it really gets at the humanistic element of medicine. It's like one thing that really drew me to the field. So it's like really cool we had this opportunity to really engage with that on the clerkship. Yeah. So one question I had, follow-up question about that is like when we're tying some of that information to our presentation, like what's the best way to incorporate that in the presentation, and like when and where to give it?
So I would say on day one, so when you start your rotation, you may already have patients that you're going to be following. But on day one of hospitalization, when you're presenting your H&P in that social history, that's a chance where you should push yourself to include something unique about that patient. If it's, I think that's the place to do it. You can also let's say you're just starting the rotation, you're getting to know your patient, they've been hospitalized for some time. When you're giving your one-liner, you could say, this is a 54-year-old woman who previously was a national US soccer player. Like you can put it in there, for instance, but you don't need to force it. Like I would say when it's like that H&P on that first day that you're presenting, and you have that, because that's like the place to incorporate it. Though one of our program directors at Hopkins, he would actually want you to say something unique as part of the one-liner to show the humanistic aspect of medicine. But I would say, like, as you're starting your clerkship, like focus on the epidemiology, the relevant epidemiology, the tempo of disease, and the clinical syndrome, the who, the when, the why. But incorporating the social history into your H&P. Not just smoking, not just alcohol, not just drug use, but who are they? Who is this?
Yeah.
This 78-year-old grandfather of 20 kids, or something like that. Something that's just striking or makes them, a human.
Right. Absolutely. Okay. And then I also want to follow up about like the time that we're spending reading and like learning like about all these diseases. I was wondering if you could talk a little bit about like illness scripts and how to essentially like chunk the information that we're reading and learning about these diseases in a way that allows us to like interweave them with the problem representation to like come to the diagnosis and do that clinical reasoning.
Absolutely. So the illness script is basically your book chapter for a disease. You can read more about illness scripts on clinicalreasoning.org, where they have like a great framework for an illness script and examples. But the illness script, so the problem representation is your framework of that patient's like presentation. And that might change from day to day based on data that comes. The illness script is your book chapter for a disease. So basically imagine like the problem representation is like the keywords you enter into a Google search engine. The illness script is like what Google fires back at you as like the possible solutions. So when you create the frame, and that's why framing is so important, because if you create the wrong frame, you're going to get the wrong DX. But if you create the right frame, if you enter the right terms into the Google search engine, then it's going to look for a matching illness script. So the illness script is going to have many of the components of the problem representation. So the illness script is going to be like who's at risk of this specific disease. So for example, someone with cellulitis, the who might be if they have lower extremity edema, if they have tinea pedis, where they have like a breach in their skin that might make them vulnerable for a bacterial infection of the skin. or a patient with diabetes, or a patient with kidney disease who's immunocompromised, or a patient with lymphedema that like affects the circulation. That's the who, that's the epidemiology. The illness script has the why. The why is like the pathophysiology of disease. So when you're learning about cellulitis, like why does cellulitis happen? If you understand the why, the rest of it really like makes sense. The why is that there's like usually a breach, a bacteria on the skin, staph strep, enters and causes inflammation of the subcutaneous dermis. And now you have the understanding of why. So you have the who, the why, the what is the clinical syndrome. So you have the who, the why, the what. But before we talk about the what, I would say the when. So the who, the why, the when is like the tempo. Like cellulitis doesn't have, it's not like someone goes from normal skin to just abnormal skin. You know, maybe they recognize it all of a sudden that it's abnormal, but it usually takes, like, it's acute. It takes a little bit of time. It's not hyper acute like an MI, like a heart attack, where someone's like normal and then there's a plaque rupture. Like, oh, you know, it's like more grave, but it's not as slow as someone who's developing dementia over years, you know? So the tempo I would say is acute for cellulitis. Then the what is like, you get this red, maybe like not like perfectly demarcated, warm, painful, swollen finding on the leg or anywhere, you know, that a bacteria can enter. So you have the who, you have the why, you have the when, you have the what, and this is how you should learn all your illnesses. Then I added a section. This is like illness script 2.0. What else? This is like your like rare complications of cellulitis, for example, or your rare manifestations of a disease is in the what else. Then you have the DX, which like the DX is just can be made clinically. You don't have to necessarily obtain blood cultures. Sometimes you will. And then the RX, which is your treatment. So it's like the who, the why, the when, the what, the DX, the RX. But like, let's say you're presenting this and the patient came in with a red leg, you shouldn't just say it's cellulitis. You should say like erythematous leg, or you might, it actually might be SIRS, or it might be inflammation is your number one problem. Most likely source the leg because it's red. The patient doesn't have any respiratory, gastrointestinal, or urinary symptoms. The red leg probably represents cellulitis, as there's a leukocytosis, it's warm, etc. But 30% of the time, cellulitis is erroneously diagnosed. Other possibilities include lower extremity edema, but I don't think it's edema because it's unilateral. It's not bilateral. I don't think it's contact dermatitis because there's no allergy. It's a little too diffuse for contact dermatitis. It fits better with cellulitis. Then the do not miss. It's always good to include do not miss. So in your DDX, the do not miss is necrotizing fasciitis. That's like an infection of the fascia that is fatal unless like intervened upon emergently. I don't think it's necrotizing fasciitis because the patient just isn't that ill, though there's actually a scoring system called the Larinic scoring system, but that's sort of the way you want to do it. It's like SIRS or inflammation or sepsis. Problem number one, most likely sources are right leg because it's red. I don't think it's GI. There's no GI. There's no other localizing symptom. I think it's cellulitis because of X, Y, and Z. It's like, that's your illness script. Other possibilities include stasis dermatitis, but it's unilateral, include contact dermatitis, include Charcot's arthropathy. A do not miss, and you might actually lead with it. Do not miss is necrotizing fasciitis, but the patient just isn't that sick, is improving on our antibiotics. And yeah, so maybe you actually challenge yourself on day one to say do not miss, but you don't have to always do, like, let's say if someone's coming with like 3 weeks of shortness of breath, looks fine. Like, you don't need to see do not miss is, you know, this condition. It's like, you have to be practical. But if someone comes in with jaundice, a do not miss is like cholangitis, is acute liver failure. That's another way that you should be learning these, like, you know, topics and frameworks, is like, what is your do not miss?
Yeah, I think that's a great overview of like how to approach, you know, sort of taking our learning and matching that with like the patient's, main problem in performing our clinical reasoning. Yeah, so I guess just like to wrap up like on these questions, is there any other advice you would have or closing insights
Yes.
for medical students
All
for the
right. So
lesson?
here now we're going to go into like just proper etiquette.
Mhm.
Proper etiquette. Let's say I ask your friend Sylvia a question. I didn't ask you the question.
Mhm.
Let's say Sylvia doesn't know the answer. Please don't answer the question unless I've asked you the question. I would never, because one, why would you want to like make your colleague feel bad, right? Or even worse yet, like I asked the senior resident a question, and let's say you know the answer, because medicine is so broad, you might know something that I don't know. You shouldn't, like, I know you're probably excited to show what you know, but that's not the right etiquette. Don't answer a question unless asked upon, or if it's given to the group, because you just don't want that kind of reputation. Two, don't like, I've had med students like ask me for feedback on day one, day two, day three, day four, day five. No, like that it might be too much. Like for me, I'm able to tell them, but some attendings might just view it as like too invasive and they may not give the feedback, but I will give the feedback and I've done it. And the person like flourish and like stop asking for feedback every single minute. So it's situational awareness. Let's say your team just admitted 10 patients. Maybe that day is not the time to ask for feedback,
Mhm.
but feedback is important. And so, you should get mid-rotation feedback and end of rotation feedback. I personally like to give feedback on the fly and I like to teach on the fly. So like, it's like a regular occurrence. So don't answer quite, this is all just like common sense. Don't be too eager. And that goes into that line of like not answering questions that you're not asked. Not asking for feedback every 2 minutes. Like if you're too eager, being enthusiastic is different than being eager. Being confident is different than being arrogant.
Mhm.
So you just be mindful of that. And you just don't want to come off as too intense.
Mhm.
Be there to augment the care we provide. We should focus on your growth. That'll be one of many things that we're doing as a team, but be there, try to like be a help to the team. So be relaxed, be calm, work on your oral presentation skills, set like subtle like goals for like specific goals for yourself that are doable within the rotation. And I personally love just like spending that time at the bedside. So yeah, that would be like my overall advice to the learners. It's internal medicine. Like that's when I like learned I wanted to become a doctor. Like I disliked the first 2 years of med school. I actually almost quit after my first year of medical school. All of a sudden, everything you learn is for a patient. Like, when you take an IQ test, the IQ test doesn't test like what is your love for a subject matter? Like how much are you willing to dedicate yourself? It's just testing a random point. And actually, when it was designed, it wasn't intended to predict potential. So there's a great Hidden Brain podcast on this. So like that was when I fell in love with medicine. It's when I saw a human being. And then my desire to learn a disease wasn't because of the disease, though I love science. It was because of that human being sitting before me. So congratulations on all of you starting your clerkship, and enjoy it. It's a lot of fun. I know it could be nerve-wracking. I was a med student. If you can create teaching points for the team and incorporate that. So maybe on day 2,
Mhm.
still stick to 5 minutes, but you really work on a 1 to 2 minute teaching point. In community-acquired pneumonia, it takes 4 days. I learned, like reading this article, it takes 4 days for the patient to respond to treatment. Or sometimes the chest X-ray doesn't capture community-acquired pneumonia based on this article. Like working on like small teaching nuggets, that's like maybe week 2, week 3. It can really separate you. Not separate you from because who cares? You don't want to be separated from there. You just want to be the best version of yourself.
Right. Wow. Well, thank you so much, Reza. This was some wonderful advice, and like definitely for me, it feel like got me even more excited for my medicine clerkship.
It's so much fun. Like the team, like it's the time you have, like what you learn. It's why you went to medical school, is to
Mhm.
interact. And maybe you become a surgeon, that's okay, but these skills are foundational to what every provider does.
Great. Well, thank you again, Reza. You have a wonderful day. Thanks again for joining us.
My pleasure.